So, good evening, one and all present for this molecular tumor board. So, as Sir said, this is our 10th molecular tumor board from this initiative, which has been going on for some 3 to 4 months. So, this is the first case by Dr. Tara Chand Gupta from Jaipur. Yes, sir, can you please proceed, sir? Thank you, sir. Over to you, sir.
Thank you, madam. We are going with this case. This is actually a case of recurrent C ovary. The patient is a case of 54-year-old female with a diagnosis stage was the stage 4A on 25th December 2019, and the status at last follow was the progressive disease, date of relapse, last progression, that is 24 September 2025, with the performance status very good. It is 1 and without any comorbidity and no significant family history. So please move on to the next slide. So number of lines of treatment 5 and treatment details, multiple prior lines. Details I will provide. I think it is not there in this slide, but I will share details also. What treatments were given at that time. So imaging summary, the latest imaging of the PET-CT, that response was suggestive of progression of disease. Next. So at that time point, we did a biopsy and that was from the left internal lymph node, and carcinoma of ovarian origin with the papillary pattern was noted, and there was low lymphoid tissue was observed in the microscopy. Only the papillary pattern is there. So further, the ISC was done, that is suggestive of the Ki 67-60%, and that was suggestive of the WT1 positive, PAC6 positive, and it was suggestive of high-grade serous ovarian cancer. Next, release. So before this line clinical question, can we start trastuzumab register? There are some slide reports which are, I think, not there in this slide. I think in next slide it is there or not. I think. Yes, this is the report of the NGS that was done. That is suggestive of T53 frame shift and missense mutation, and the ERBB2 expression was present in NGS. Although FISH report is still pending, I think we will get in 1 or 2 days. I think we have sent it 7 days back. So 7 or 8 days back. So it is pending. So if you another next slide, please. So it is also not next slide, please. No other mutations was identified. Yes, on ISC, ER was also present. That was, I think, 80%. ER positivity was there on 80%. And this is the one more slide that is not there only. There are the observable mutations were only P53, frame shift, and the missense and the NGS ERB2 positive. ISC suggestive of ER 80%. Next slide. If you want, I can share, if you allow me, I can share some PPT which can show you the another details of this case. So should I share?
Sir, you can yes, actually, yes.
I can share or not? The other details of this case?
So what details you want to share, sir?
The treatment details and etc.
Can you just tell it oral? If you want to share, you can share. Otherwise, you can say by oral also, sir.
Okay, the patient was already treated with the paclitaxel, carboplatin, lipodox, bevacizumab, and the last drug was the bevacizumab and olaparib was there. Before that, patient has taken only the lipodox, paclicarbo, gemcarbo, all the drugs were taken, irinotecan also.
Okay, 2019, the patient was diagnosed as stage 4, or at that time it was stage 3, sir?
Yes, this was a stage 4. Just I share another details. I think there will be some confusing things.
Okay. Okay, sir, what was the platinum sensitive, when was the last platinum given and how was the response, sir?
Last platinum was given, I think, this was 2 years back.
2 years back, okay. Okay, so how was the response to last platinum, sir?
Sir, after that, we put up the patient on the bevacizumab and olaparib maintenance only. So it is the last. That's why I was sharing the slides. If you want, you can.
No issues, sir. No issues, sir. I think this information is enough. So the question by the presenter is: can we start trastuzumab
No,
deruxtecan?
the questions are like this. Although this was yes prepared way back, and the things are that one thing, that patient who has been treated heavily previously and multiple lines of treatment, including the platinum, irinotecan, that means the topoisomerase inhibitors, and anti-VEGF and BRCA mutation also. So still there are chances that we will get only on 2-3 mutations in this type of cases, which is now looking like a resistant case. Because my understanding is that whenever the case become old in the cancer and it develops the mutation, that's why tumor creates give the resistance to the treatment. So we got only these two mutations, P53 frame shift and P53 missense, and along with the ERBB2 only. Although ISC is strong positive for the ER 80%, but we still not be able to mention that can we use capivasertib or other drugs or not.
IHC by head to done here, sir, or only ER done, sir?
Yeah, 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 yes.
Head to new IHC fish this patient by any time.
No, we have sent HER2 by fish, and this ERBB2 was positive by NGS in this report only.
Okay, sir. The last platinum, along with platinum, what was the chemotherapy given 2 years before, sir?
Most probably, I think gemcitabine carboplatin.
So gemcitabine carboplatin followed by bevacizumab olaparib maintenance for the past 2 years.
Yeah. If I can share, I show you that 6-cycle paclitaxel carboplatin and 2015, then recurrence in 2019 with Omental met, paclitaxel carboplatin again, then lipodox carboplatin, then CRS again. That means cytoreductive surgery was done, and there was no molecular, there was no disease. Then tamoxifen, and then the patient gemcitabine carboplatin plus bevacizumab, and after that patient was on the bevacizumab plus olaparib maintenance till now.
Okay, thank you, sir.
Okay, fine. Narendran, I think we got a gist of the case. Okay. Personally, I'll start my opinion. Probably people, others, experts can start. So there's one is first question asked by the presenter is can we give trastuzumab deruxtecan? As we know, if it's HER2 is IHC positive, it's tumor agnostic. We all know. Otherwise, based on HER2 mutation alone, I think it's approved only in few cancers. OG junction, non-small cell lung cancer, breast. These are the few areas where deruxtecan can be given based on the mutation. Otherwise, if IHC is positive, yes, definitely it's tumor agnostic. This can be done. Second point is platinum-free interval is nearly 2 years. So patient has been platinum sensitive. So re-challenging platinum is one thing I would like to consider. This is the second. Third is definitely another is folate receptor IHC. So HER2 by IHC and folate receptor by IHC may be helpful now or in the future. These are the three thoughts.
Dr. Arun, here from the one point from my side is there that you have given 3 points. One thing that you are again and again mentioning that ISC for the HER2. So is this fish is more reliable or ISC? Because I have sent fish for yeah.
Both are fine, sir. Both are fine. If fish is positive, then straight away you can go. Otherwise, IHC both are. Yeah, both are fine.
Yeah, because that is now approved for the trastuzumab deruxtecan. Second thing,
Yes,
you are mentioning that platinum again. So we have introduced the platinum as per the clinical criteria that the patient is platinum sensitive. But is there any marker in this report that can suggest that the platinum will be good for that?
Yeah, sir, here if you see the HRD positivity is HRR genes are. Yeah, so there is no choice whether the patient will be sensitive or not. So, but medical profile and history, what you are giving, it looks like 2 years period. Patient will be sensitive. What I would like to suggest is we'll take all the opinion, then Dr. Narendran with the consensus, then you can pose more questions, sir. We can take all others' opinion.
Okay.
15 minutes per case. So we'll.
Dr. Denisha ma'am, I think are there in the both,
Yes.
sir. So we'll ask their opinion also.
Get
sir.
opinion from all the experts, then
Yes.
Dr. Chandralekha and Dr. Narendran will give the consensus. Then you can post more questions, sir. Over to others, sir, for their opinion.
Yeah, hi, sir. Kripa here. So
Good
I
evening,
think,
sir. Yes, sir.
hi, Chandralekha. Hi.
Sir, can we have the molecular experts comments and then give your
Yeah,
clinical comments?
absolutely.
We have
Let them.
not commented it.
Arun sir is here. I think he can.
Sure. Thank you. Hi, good evening. Thanks. I just had one point here. This test particularly has been done both in the tissue as well as in the blood. Now, interestingly, this HER2 point mutation is seen only in the tissue and in a very low VAF. The VAF is 1.58% and the tumor content is around 60%. So it's around 2.53% is the around 3% is the VAF, and it is also labeled as subclonal, meaning that it's a very small clone that is coming up in the tumor tissue, and this may not represent the entirety of all the tumor cells in that tissue. So already Dr. Arun had clearly he said about TDXD in point mutations not being approved, and this is again another point which you may want to consider because this is subclonal in nature and it is a point mutation in nature. So that is and it was not picked up in the liquid biopsy, that is in the plasma the same mutation was also not picked up. So that's another point of contention that you may want to consider. So apart from this, I don't see any other genomic marker particularly showing sensitivity to platinum, nor is it showing resistance to platinum.
Can we go to the NGS report, sir?
Hi, sir. Dr. Dinesha here.
Can we?
Yes.
Can you change that slide? Yeah. Thank you. Yeah,
Yeah.
proceed, sir.
You can just zoom in here. You'd be able to see the VAF.
Yes.
It's 1.8% ERBB2. This is an activating mutation that I checked. Yes, 310Y is a known activating mutation. It's there in the extracellular domain of the HER2 molecule. I think this was also included in one of the TDXT trials in pan TDXT trials where one of the cases did have this, but not sure of the response and stuff. So this is a extracellular domain mutation, and it is very low VAF. So these are the 2 points I wanted to notice. Yeah.
Hi, sir.
Dr.
Dr.
Arun Kumar,
Dinesha here.
Dr. Arun Kumar, Dinesh, one question.
Yes, sir.
Presenter asked why so few mutation in such a heavy treated cases, sir. Can you answer that question also? Then we can go to Dr. Dinesha.
Sure. That's very difficult to answer. Like, I'm not really sure why there are very few mutations. Maybe the nature of the tumor is such that it's not mutating that heavily. Nor do I see the classical gene, DNA replication gene mutations like BRCA or others, which you typically see in ovarian cancer. But TP53 is there, and you do have quite a few VUS mutations, right? And that is, I think I saw it somewhere in the behind. So, but no actionable mutation. So I think why it is not there, I don't think we have a clear answer for it. It's to do with the biology.
Thanks, Dr. Dinesh.
Sir, how about adding a hormonal therapy in this case, sir? Because for the low-grade serous ovarian cancer, generally for the ER-positive case, letrozole kind of drug are added. How about in this case, sir? Since this is the ER positivity is strong, around 80%.
Kripa, sir.
Yeah. So I think here, I think it was mentioned that this is a high-grade serous ovarian carcinoma, if I remember.
Yes, sir.
Number one, and the other thing is the presence of a P53 also. You see, we talk about BRCA and P53 being more common in molecular type 1, which is high-grade serous ovarian carcinomas. So I think, but the clinical behavior here is not suggestive of high-grade serous ovarian carcinoma. I think that's where the dichotomy is. Because this patient has been going on from 2019 up until now with stage 4 disease, right from the beginning for close to 7 years. But nevertheless, seems to be still platinum sensitive because I think the last platinum was 2 years earlier. So the platinum-free interval is definitely around 2 years. So I think I would stick to re-challenging with a platinum-based doublet, and the performance status is also good. I think that's what the presenter also said, PS1. So I think go ahead and re-challenge with the platinum, preferably oxali. I mean, like if the patient has already had too many carboplatins, could go ahead and give him platinum-based doublet here, and then subsequently do a folate R1 receptor, as was also suggested as well. Once the patient becomes platinum resistant, I wouldn't want to act on the HER2 activating mutation right away, because I think the approvals are definitely, it becomes an off-label indication right now to use TDXT in this particular subset of patients for this indication. So I think that's my take home.
Yeah. Yeah, even I agree with Kripa. So here, using hormones, see, hormones are static actually. Patient is progressing 2 years platinum free. Probably platinum is what we all will consider, because that's what it works. So at present, we won't give much importance to estrogen receptor positivity. Better to use platinum and always use estrogen receptor positive at a later date. If no options are exhausted, hormones can be tried.
What if the fish for head to new comes positive here, sir? Any other options here?
Yeah, definitely. See, Narendran, if you look at the pan-tumor O2 data for HER2 IHC3+, TDXT is now approved as a tumor-agnostic therapy as well, irrespective of the site of the primary. So if the IHC turns out to be 3+, then yes, TDXT becomes an option. But even then, I would probably look at doing a platinum here, and then, because obviously the platinum-free interval is more than 2 years, and the patient seems to have been doing so well for 7 years now with ovarian cancer, stage 4 high-grade serous ovarian carcinoma. So I think I would be more tempted towards doing a platinum here, and then, even if the IHC is 3+, hold back TDXT for later. But it is approved as a tumor-agnostic indication if your HER2 turns out to be IHC and 3+, based on the pan-tumor O2 data.
This patient solid, the liquid biopsy report is there here, sir.
Yeah, it's
I think
combined.
this is the
It's combined. See, the first TP53 is plasma DNA. The second TP53, 50% VAF is tissue DNA.
See,
okay.
here the
52
tumor content is 60% and tumor fraction is 37%. That 37 means what has been positive in liquid biopsy is what is that
Yes, sir.
37 tumor fraction means?
So out of the DNA extracted from the plasma, 37% of them had tumor origin.
High,
So they
very
could
high,
be-
right?
It's pretty high. It's pretty high.
Very high, right? We don't
Yeah.
see such a
You don't
percentage in.
see. Absolutely, absolutely.
So for that percentage, so less mutation that has been detected, is it something not correlating?
I don't know to answer that, sir. Possibly, yes. Generally, in heavily pre-treated, you tend to see a lot of mutations. And but in this case, we don't find. But clinically also, I think the patient is not in a very aggressive nature of behavior, right? So not really sure. But
Not
tumor fraction is considerably high. You rightly mentioned, so. This you see only when you have a lot of metastasis in the body.
Absolutely. Unusual.
And also the TP53 mutation, which is found at the VAF of 50.6%. So that is found at a very minimal level at the plasma DNA. They have added as a note here in the bottom.
Okay.
Can we conclude this case for the want of time, and can we put on the consensus, sir, for this case?
Agree,
Yes,
Dr.
sir.
Chandran.
Yes, sir. So,
Before concluding, madam, may I put some and give some inputs, or may I ask some questions so that at conclusion will be a better in a better position?
yes, sir, please, sir.
The one thing we are missing, that the PDL1 CPS is 8, and this we are showing. Second thing, ER is 80%, still patient is ESR1 negative. Two things. And third thing, patient was HRD negative at baseline, also with the germline BRCA1 negative, and patient still responded to olaparib plus bevacizumab for the 2 years. And yes, we are discussing the platinum because of the platinum-free interval. So yes, that is a common gesture. So I would like to, or yes, we have discussed that the heavily pretreated patient is having low mutation burden only. So please have the look in these 3 points also.
Okay. Fine. So PDL1 CPS of 8%, I don't attach much significance here. And we know ovary is mostly it's a cold tumor, unless any other tumor agnostic approval, MSI or even TMB is not a good biomarker as far as the ovary is concerned. So I won't attach much significance to the PDL1. Estrogen receptor already we have discussed. Probably now platinum-free interval will be a better pathway to target rather than estrogen receptor pathway. That is the second point personally I thought. So others also can opine. Probably we can before going to the consensus. And why patient has responded so well to platinum? We are now NGS is not giving any clue. We don't have any positivity as far as the PARP or DNA repair gene, any pathways involved, or HRR gene pathways involved. We don't have any clue as such. The NGS report is so either the NGS can be rerun to really see are we missing anything, or in this case directly go for platinum re-challenge.
Okay, the points noted, sir. If any other points needs to be included, we'll have their opinion also. Otherwise, we'll conclude and move to the next case, sir.
Ma'am, one more thing is that you can go after that, move on. One thing you people are mentioning that TMB, right? So if TMB is the marker, but if I'm quite aware that that study of TMB, the patients who were responding to the immunotherapy were the MSI high. If we can remove that segment or that subgroup of the MSI high patients were not responding to the TMB high group. So what is your take that if the patient is MSI negative or there is no MSI high and the TMB is high, then will it work or not?
Sir, I don't know, because there are 3 different markers, and most of the MSI highs tend to be TMB high, but not the vice versa. Whether only TMB high is a good marker, I would not. I mean, it depends on what is the mutation load. You also see TMB high when you have pol E mutations or mutations in other DNA repair genes. So I think it's very context specific.
So can we take that if the mutation load is more and then the TMB is high, then it's a significant in that way, Arun sir?
No. Can you just repeat, sir? Sorry.
When the mutation load is more, other than MSA like POL or other HRR genes, when the mutation load is more, when the TMB is more, in that way it is more significant, then immunotherapy can help there. That's what you're mentioning, sir.
That's what I'm trying to say. Yes. But see, the other point is that I think in the previous tumor boards also we discussed TMB should also be looked at in the context of the histology. Different tumor types have innately higher levels of mutation load than others. So I think moving forward, we should also have that in mind while analyzing the TMB. Particularly when you have TMBs in near the cutoffs of say 11, 12, 13 or 9 or 8, they become very difficult to interpret.
Yeah, and so just to add to that, I think, when you have somebody with MSI high, the incidence of TMB, roughly the concordance is around 70%, number one. And number two, TMB is not just based on the MSI alone, it's also based on the tumor microenvironment, like your TILs, your TAMs, your T regulatory cells, T effector signature cells, MDSCs, all of that combine or go towards making your TMB. And your TMB values vary whether you're doing it on tissue or on liquid biopsy. Because on tissue, we use a cutoff of more than 10 mutations per megabase, which is what the current approval stands for as far as tumor agnostic therapy is concerned. But whereas if you're doing it on liquid biopsy, the cutoffs are much higher. Like, for example, Foundation 1 uses more than 28 mutations per megabase on blood. And likewise, for Guardant also, it's around 30 mutations per megabase. So always remember that TMB, like Dr. Arun sir also rightly pointed out, has to be interpreted based on whether it's done from the tissue or from the liquid, or also on the underlying solid malignancy that we're talking about here as well. And it's not just because there are other, like for example, Tempus does a scoring called the immune profile scoring, IPS score, which it takes into account all of this tumor microenvironment as well. CD8 positive cells, CD3 positive cells, and then again puts everything together before they give a score. So I think DMB, definitely relies on a lot of other things and not just the MSI alone.
In this case,
this case, we have discussed ovary and TMB even last tumor board.
The 11 mutations per megabase, we thought that was.
So last tumor board also, and we all know that whatever the approval based on the keynote study, TMB, the subgroup analysis, 2 or 3 solid tumors didn't do well. One is ovary, colon, sarcoma. All these tumors, despite having TMB positive, they didn't do well when we went for the subgroup analysis. So we need to be very cautious, particularly in ovary, basing our decision on TMB for immunotherapy. We need to be very cautious.
In this particular patient, we are suggesting for a platinum re-challenge. And after 6 cycles, if there is a response is there, since ER is positive, can we advise for a maintenance of hormonal therapy here till progression?
So regarding that, I actually wanted to have a word. Can you just go to the next slide, please? So I need opinion of the medical oncologist also here. See, I see even in Tempus they give now RNA report is coming, and you are seeing expression of ESR1, the third gene here, with a I think copy number of 5. I don't know what that is. 5.021. Is it a copy number or is it some other number? I really don't know. So ESR1 with this 5, I presume it's expressed more. I really do not know whether to take that as possibly a future resistance mechanism for hormonal therapy, because this is RNA based testing and it's not a approved biomarker either. What is your take on this? Would you decide to give a hormone therapy based on this RNA testing?
I think, again, to answer your question, sir, I don't think I would, rely on the ESR1 here. I think, whatever we talk about as far as breast cancer is concerned, are the ESR1 mutations, activating mutations that we talk about. So I think my decision here to offer hormonal therapy will not be based on this. And I probably would not be too keen on offering hormonal therapy here as maintenance as well. Probably, I would be, since the patient has done so well on PARP inhibitors for a long time, despite being HRD negative, that tells me that probably there is something else like the BRCA-NUS or BRCA-like phenotype, which is probably driving the platinum sensitivity. So, and there is data in ovarian cancer to probably look at re-challenging PARP inhibitors as well, the NGOT Oreo trial, as we would know it. So probably, if the patient has got very good platinum sensitivity, even again, if the patient responds to platinum again, and when we re-challenge right now, I might want to, go ahead and re-challenge PARP inhibitors as well.
I just want here, anybody would like to repeat an NGS in this case? I'm seeing a lot of discordance.
Probably in the future.
Probably a HRD testing, because I don't know how this HRD was done here. What scoring system was used, whatever was it? Definitely not the Myriad My Choice CDX test. That was not done here. So probably might be worthwhile doing if the patient has got no financial constraints, offer a Myriad My Choice CDX or companion diagnostics for HRD to see if the patient's HRD score is actually positive, and so to see what's driving the platinum sensitivity.
Sir, I have one question. Krupa sir, do you trust the AmoyDX?
Sorry?
Do you trust the AmoyDX HRD results? AmoyDX has the genomic scar score, right? Which initially AstraZeneca was promoting for
Correct.
3 to 4 years. That AmoyDX is based on genomic scar score, algorithm, right?
That's right.
Do you trust that one, sir? Do you trust that for your? Have you seen response based on the that approach?
Yeah, on a lighter note, I think there are a lot of other companies that are actually running their own, HRD tests. So we call it the genomic instability score (GIS), which is what was originally used in the myriad.
Myriad, yeah.
Exactly. Then you have the genomic scar score,
Mm.
rightly pointed out, which Strand also does. Then you have the GAS or genomic aberration signature as well, which
Oh.
other labs are actually reporting. And that's
Okay.
the reason why I said there's a lot of dichotomy here. Whichever lab is being used.
But this AMOI-DX one, no sir, what is it's a off-the-shelf assay, similar to anything that you. It's not in-house derived, but it is supported by clinical trial outcome, right?
Absolutely. See again the cutoffs. See, if you look at
Uh,
genomic instability score, the cutoff is more than 42. Whereas for the star score, it is more than 50. You're indirectly looking at the same alleles, but the loci of the alleles are different, number one. And number two, again, when you talk about, the loss of heterozygosity, telomeric allelic imbalance, and large-scale state transitions, that was directly looked at as far as the myriad my choice CDX. Whereas the genomic scar score looks at the length, type, and site of copy number variation. And that's how, we are indirectly deriving these parameters. So, even though the concordance is to the tune of around 80 to 90%, it's not 100%. And that's the reason why I said if the patient has got no financial constraints and probably you're very interested in knowing what's driving this platinum sensitivity, might be worthwhile doing it on the approved, the companion diagnostic for HRD.
Okay, sir. Sir,
any role of ADCs in ovarian cancers? Hello, I'm Dr. Balaji. Can you hear me?
Hi, sir. Yes, sir.
Good evening, Kripa. That was a nice discussion. Role of ADCs in ovarian cancer in such resistant cases and.
See, none of them have been approved so far, sir, unfortunately. But then again, there are people looking at even CAR T cells in solid tumors based on CDH expression, B7H3 expression, B7H4 expression, B7 family of receptors. So it's all being tried out. It's all being looked at. But unfortunately, apart from TDXT, which has got a tumor agnostic approval for HER2 IC3+, none of the ADCs have actually been, apart from mirvetuximab soravtansine as well, which is, for folate R1 receptor expression positive patients alone. In the
tissue factors?
No, sir, that is tisotumab vedotin that is approved in cervical cancer and it's not yet approved for ovarian cancer. So for ovarian cancer, it's only mirvetuximab soravtansine based on the folate R1 receptor.
What is the target for the
the ADC target is folate receptor 1 alpha.
For the tissue factor, my question is, most of the ovarian cancer will have a antigen, in as a tissue factor.
So that's what, sir. The tissue factor expression has been more found to correlate with cervical cancer, which is why in the Innova TV trial, which looks at tisotumab vedotin is the drug, which is tissue factor, and that's already approved in cervical cancer. But not
can that tissue associated antigen be used agnostically for all gynec malignancies?
Unfortunately, no, sir, because we don't have the data or the evidence or any. It's not approved as well for all the gynecological malignancies, sir. Only in cervical cancer as of
ongoing trials.
There are a lot of ongoing trials, sir. Not
ADCs.
Yes, sir.
In gynec malignancies?
Absolutely, yes, sir. Like I said, there is even ongoing trials looking at cellular therapy as well. Apart from ADCs, and even the ADCs as well, targeting B7H3, CDH6, all of these are ongoing, sir. None of them have been approved yet. So sorry, sir.
Sacituzumab.
Correct. Sacituzumab govitecan is also not approved in ovarian cancer, sir.
No trials.
Sir, considering time, can we have the questions in the text? We will reply it later, sir. We will move on to the next case. Can we have the questions in the chat box? We will address it separately, sir.
Okay.
So, final, this patient, high-grade serous carcinoma with good biology disease, since platinum sensitive. Final consensus here is re-challenge platinum. And then in the future, maybe consider for transplant deruxtecan based on the NGS, and also may consider for doing HRD since the patient is a platinum sensitive for a longer time in with a companion HRD test, probably a Tempus. So this is the final consensus. Maybe we can move on to the next case.
Thank you, sir.
Thank you. Can I present?
Yes, ma'am. Please proceed, ma'am. This is case is presented by Dr. Sharda, ma'am, from KMC Manipal. Over to you, ma'am. Please proceed, ma'am.
For rescheduling the case for me. She's a 36-year-old female who presented with the malignancy. She had a mediastinal mass, and that was biopsy proven to be adenoid cystic carcinoma with multiple metastasis, bony and soft tissue metastasis, nodal metastasis, stage 4 at diagnosis. This presentation is at diagnosis. She has only undergone palliative RT. Next slide, please. So there is no relapse. She has just undergone palliative RT. We sent an NGS because it was adenoid cystic carcinoma. Next slide, please. Next slide, please. This was the NGS test we sent. Next slide, please. Next slide. So as you can see, next slide, please.
Oh, we have reached to the end of the slides, ma'am.
Yeah. Can you show the next slide? So we only found this mutation, BARD1 mutation, with the which is also a variant of unknown significance. So we just wanted to know the significance of this kind of mutation in an adenoid cystic carcinoma, whether we can target it with PARP inhibitors after her chemotherapy.
Sharada madam, myself Vidya here.
Yes, ma'am.
So we should not, target this, madam, because this is variant of uncertain significance.
Okay.
Yes, madam.
Okay, ma'am. Just.
So Sharad, what therapy have you planned for her?
I thought CAP chemotherapy.
She's fit. Yeah, I think if she's fit enough, I think I agree with your plan of CAP. And how symptomatic is she now? I mean, like after the PAL-RT?
I'm yet to see her after the PAL-RT, but I think during RT itself, her symptoms had come down. So.
And might well again checking on her HER2 and AR as well.
I think this panel did a HER2, I think.
Yes.
IHC. On IHC.
IHC is important. HER2, at least amplification is not there, sir. And also there is no mutation, both.
What else, sir? HER2 and AR?
Yeah, AR.
I'll get the IHC on the block at in-house itself.
And if she's very symptomatic, CAP, otherwise even lenvatinib also is an option. Multikinase inhibitor.
Maybe at a later line, I thought currently she's fit. So, and she's high disease burden as such.
So, right. I mean, like the volume of disease is high and she's very symptomatic and you want a rapid response, then CAP is a very good option. Else, lenvatinib is another option as well.
Thank you so much. Thank you, sir, for giving me this opportunity.
Is there any discussion on this IHC report? The pathologist is here.
Sir, there is CD117 positive, madam, in your IHC report. I saw that.
Can you go on to this IHC report slide?
Previous page, slides, I think so. The previous page.
One more page previous. Previous page. Again, previous. Yeah.
Sir, this looks all right. I'm Dr. Chandramoleshwari here. So this IHC report looks okay only. So luminal and abluminal both cells have been stained for. So myepithelial cells are positive, and at the same time CD117 is also quite a specific marker for adenoid cystic along with morphology, of course. Anything in particular in IHC, sir?
spoke to our pathologist, so she was also quite sure that this is adenoid cystic.
Okay. Thank you. Thank you.
Any role of TKI against CD117, sir?
So all these multi-kinase inhibitors act on KIT as well, ma'am. Like for example, which we just spoke about, multi-kinase inhibitor has activity against KIT as well. So that's absolutely there, ma'am. And earlier on, I think imatinib was actually being used a lot, but now we've moved on towards multi-kinase inhibitors like imatinib again, and the data for that as well in adenoid cystic.
So then there is a very strong correlation that a TKI will work effectively for this patient's tumor, looks like.
Definitely, ma'am. But like Dr. Sharada rightly pointed out, I think the patient's got large volume of disease and is currently symptomatic, and that's why the patient has had palliative RT. Considering that, she wants to go ahead and start off on chemocytotoxic therapy with CAP regimen and then plan for lenvatinib later. So that's justifiable.
Okay, this patient is a young female with a mediastinal mass with multiple site metastasis. His final diagnosis is adenocystic carcinoma without any actionable mutation. So the plan is to go for the chemotherapy as decided and check for the HER2 and AR also by IHC. Thank you. Next case.
Next is we have Dr. Raj.
Hi, ma'am. Good evening, ma'am. Shall I start the case, ma'am?
Yes, sir. Please, sir. Over to you, sir.
Yeah, yes. This is one 41-year-old female patient. Patient initially presented with obstructive jaundice to me. That time it was on October 2024. That time patient undergone ERCP plus biliary stenting, and after 4 months she underwent surgery, ma'am. But no imaging was done at that time before surgery, and patient underwent Whipple surgery. And followed by surgery, she again came to us. That time imaging was done, and post-operatively she was diagnosed with stage 4 periampullary carcinoma liver, and newly appeared multiple abdominal nodes were there. So we have started the patient on palliative chemotherapy. At that time, patient's general condition was not so good, and her PS was ECOG 2. So we have started on single agent capecitabine, and followed by escalated to doublet capox was started. After 6 cycles of chemotherapy, on reassessment, patient had good response in abdominal nodes, but newly appeared liver metastases were there. So we have sent NGS from the blocks, tissue blocks, and over to the next slide, please. Yeah, this is the NGS report we got from the tissue.
So this tissue is from the surgery or the progression, sir?
This is surgery tissue, sir. This is the surgery tissue. At the primary surgery, samples were sent at that time only, but rebiopsy is not done yet. And this biopsy and this NGS shows KRAS G12A mutation. So, what is the significance of it, sir? And do you have any drugs to target it? The question is for the tumor board.
So what panel NGS is this one, sir?
This is sent in Anderson Diagnostics, sir. Oncomine panel we have.
The target pancreatic panel?
I think I have sent the entire report. I think so. Do you have the report, sir?
Oncomine is a 53 gene panel, I guess.
Yes,
It's a hotspot panel.
Yeah.
Okay.
I think it doesn't cover BRCA. Can you just go there? Upper? No, okay, just down. There was a list of genes. I don't think it covers all major genes, huh? See, doesn't cover it. It just has hotspot SNVs and short indels in these list of genes.
Yes.
So I think it's only targeted panel. It's not a very broad CGP.
Okay, sir. Do we need to do biopsy from that newly appeared liver lesion, and what will be the ideal molecular testing, sir, I think for these patients?
Yeah, ideally, if you can get a broader NGS panel, a comprehensive
Yes, sir.
profiling. If cost is not a constraint, again, absolutely
Yes,
yes.
sir.
That's
Yes,
one.
sir.
And again, going back to this patient, was this an intestinal subtype or a pancreatic? You said
This is pancreatobiliary subtype, sir. But patient general condition was not so. So we have started on single agent capecitabine at that time, sir.
Okay.
So she was almost wheelchair bound at that time. So, but during treatment, she recovered. Her performance status improved better, sir. So
Okay.
later we added oxaliplatin also along with it, sir.
Okay, and how is the person? I mean, like, how is she responding now? Is it disease?
Clinically, her performance status improved, sir. But on PET CT there is response in abdominal nodes and liver lesions, but few newly appeared liver lesions are there, sir, in the recent PET CT. Yes.
And you want to know if you can target the KRAS G12A because
yes, sir. Yes, sir. Do we have any options for that patient? Because I think after the second line of chemotherapy, she won't be that much eligible for any cytotoxic chemotherapy, sir.
Yeah, I think if you look at standard of care, she's not been exposed to irinotecan or
Yes, sir.
nanoliposomal irinotecan or Naliri is an option.
Yes, sir.
In combination, that's standard of care. And
Yes,
you asked about regorafenib, right?
Yes, sir.
That's your question. So rather than regorafenib, even if you want to do an off-label indication, I would look at using a MEK inhibitor, because targeting the downstream signaling pathways. You can use tremetinib, but that's later line. You've exhausted of care option. You can look at that as an off-label indication.
Okay, sir.
Directly targeting it, you'll have to look at clinical trials. For example, daraxonrasib is a pan-RAS inhibitor. So, get enrolled in clinical trials. But I think the next line of the patient fit enough to receive it should be Naliri or nanoliposomal irinotecan or from Servier. I think that's already there. And again, the data for regorafenib, there's a trial called the REGO-NIVO. Basically, it's in colorectal cancer where even if your MSI is stable, they look at using a combination of rego plus nivolumab. It's called REGO-NIVO in CRC as well, where it helps overcome the cold tumor microenvironment. So, but that's again not in pancreas. So the data for doing that in pancreas is not very great as far as regorafenib is concerned. So it's very limited data for regorafenib in that sort of a setting. So I think my choice would be nanoliposomal irinotecan in the next line. And then, if at all you want to use off-label indication rather than regorafenib, I would use tremetinib, MEK inhibitor, to target the downstream signaling pathways, or look at enrolling the patient into a clinical trial for targeting the KRAS G12A mutation that's seen here, or a pan-RAS inhibitor, like daraxonrasib. This is a class and example.
Okay. Dr. Arun here. I agree with Kripa. One thing is this NGS based, we cannot alter our treatment. Definitely, patient irinotecan is there. Multiple options are the further lines are there. Probably BRCA is one thing, as Dr. Arun Kumar said, we can do BRCA. It's indicated also. We definitely need to do BRCA in pancreatic cases because it's approved and it's PARP inhibitors are approved. So one option we'll miss out either now or in maintenance. So second thing is continue chemotherapy based further lines. Probably repeat biopsy and send a new NGS at a later date to decide on further treatment. That's what I will like to consider. KRAS per se, it's known to happen. Mutation is known to happen in pancreas. It's commonest, one of the commonest mutation what you see in pancreas. Okay. So, but this is not actionable mutation. We do KRAS G12C. Probably we have a molecule, but this we need to enroll in clinical trials. Not now, but at a later date.
Okay, sir. Thank you, sir.
Any other comments, sir, or can I go for conclusion, sir?
I have a question over here. Actually, similar case. Am I audible?
Can I introduce yourself, sir?
Hello.
Can you introduce yourself?
Yeah, I'm Dr. Sanjay Agarwal. I'm from Mumbai, medical oncologist.
Yes, sir. Go ahead, sir.
So I have a similar case of pancreatic ductal adenocarcinoma metastatic to liver, where NGS panel was being sent where KRAS G12V was positive. So there is an off-label indication of defactinib and avutometinib MEK inhibitors. So are anyone is having any experience about it? That's what I wanted to ask.
See, the data that you're quoting, sir, is defacetinib plus avatometinib based on the RAMP 201 trial, which is for low-grade serous ovarian carcinomas. So I think that's where it's currently approved as well. Whereas what we have available to us and accessible in India is MEK inhibitor tremetinib. We don't have
Yeah, tremetinib is there.
correct. We don't have binimetinib or the other MEK inhibitors. So which is why you want to contemplate using it an off-label indication. Yes, you can look at using it, but not right now. Probably later lines of therapy when you have exhausted all standard of care options, sir.
Okay, sure. Thank you.
Anytime. Welcome.
So this patient, metastatic periampullary carcinoma, post 2 lines of treatment and progression, the NGS done from the initial surgical biopsy specimen KRAS mutation is there. So the final consensus is to go for an allele now. And in future, on progression, can consider repeating the biopsy on progressive site and go for a comprehensive NGS along with MSI TMB. And based on that, may consider for enrolling on clinical trials if still KRAS is positive, or can consider off-label MEK inhibitor. Thank you.
Thank you, sir, for this consensus. And we'll move on to the next case by Dr. Isha Tiwari from MS Ramaya Medical College. Yes, ma'am. Please proceed with the case, ma'am.
Ma'am, am I audible?
Yes, ma'am. Yes, ma'am. Please.
Yes, ma'am. Good evening. I have a case of a 32-year-old female who was diagnosed with CA breast stage 3 in April 2023. Current status at follow-up is progressive disease. It is metastatic now. And the date of last progression was this year in September. Current performance status is pretty good. It's PS1. Comorbidity, earlier she had papillary carcinoma thyroid, for which she underwent thyroidectomy. Family history is not significant. Next slide. She has, when she was diagnosed with stage 3 CA breast, she had undergone neoadjuvant dose dense AC, followed by surgery, which was YPT3 N3M0, followed by RT. And then she was on tamoxifen and was on follow-up. During the follow-up, she had complained of low backache. So we had asked for a PET CT that showed metastatic progression with multiple bone mets. So then she is ER positive, PR positive, HER2 negative. She was started on palbociclib and fulvestrant. After that, next slide, sir. After that, we had sent a liquid biopsy on the blood that was reported as PIK3CA missense mutation. Also regarding her BRCA status that we had done baseline earlier on, that was reported as BRCA2 VUS, variant of uncertain significance mutated. Currently, we are planning her for alpelisib. Sir, how else to go about this case, sir? This was her NGS report.
Has she progressed on CDK inhibitors?
Yes, sir. Yes, sir. The second PET scan that we had done that showed appearance of new bone lesions. The mets are only in the bones, but she has progressed, sir.
Okay. Fine. Okay. First, I will go. Probably I agree with your plan. PIK3CA mutation is there. Either we need to target that, or we can go downstream, go for AKT pathway, pan-AKT inhibitor, capivasertib, or alpelisib. Either one of the two, probably we can plan along with a hormonal treatment. Definitely. Only thing is alpelisib, hyperglycemia management, all these things, reducing the dose, all these things are problem. But probably if at a lesser dose, many of our patients are tolerating. So alpelisib plus hormones will be a choice, or capivasertib plus fulvestrant is also is acceptable. That's what I think, and it's approved also. We'll hear from others.
So I just had a question regarding the BRCA. You said the patient had a VUS BRCA. Was that germline? The question is, reason is it's not detected here. So I was just wondering why.
It was germline, sir.
Okay. So and this is a liquid biopsy.
Yes, sir. Yes, sir.
So I'm just not sure why it was not detected here. Nevertheless, That's just a point I had.
This liquid biopsy is a complete genes they are tested, or I don't know what are the number of genes they tested here. It's a limited panel, or
It's a limited panel. This doesn't cover BRCA.
okay. How many genes tested? Is there any report? Is there? What are the genes tested here?
Yes, sir. There was AKT1, PIK3CA, ESR1, and PTEN, sir.
Only these 4 genes are tested.
Yes.
Okay, thank you.
Sir, also had a question. Sir, should we have rebiopsied every time that she had progressed?
Okay, fine. Yeah, ideally, yes. Every time when the patient progresses, taking a rebiopsy, and if biopsy is not possible, sending the liquid biopsy is the best. If possible, sending both the rebiopsy and the liquid biopsy together is always the best. Ideally, yes. But when the progression happens so fast, many times we go by the previous NGS reports.
Yeah, so
we'll hear from others also.
So what was the response to the last line of therapy, and how quickly has the patient progressed on fulvestrant with CDK4/6? How many
Sir,
the patient received CDK and fulvestrant?
sir, that cycle 5, that was last was in September, and we had started this around May, sir. So from May to September, she had received Palbase and fulvestrant, sir.
So roughly around 4 to 5 months, right?
Yes, sir. Yes, sir.
And what is the HER2 status? Is it like low, ultra low?
Negative, sir. Negative. They've written score 0, sir.
So 0. Okay. So I think, definitely rebiopsy, get a biopsy. You can check for a low or ultra low status as well. And given that, the very short progression rate, well, I mean, like we're talking about 4 to 5 months of hormone, and patient has had already 2 lines of hormonal therapy, right?
Yes, sir. Yes, sir.
And has progressed. So,
Yes.
I think probably, this tells me that the patient is becoming endocrine resistant or refractory to endocrine treatment. I mean, like if your patient can still afford, but what about the volume of disease now? Is it like oligoprogression, or is it like multiple sites of disease?
No, sir.
I think
It's only in the bones, but there are multiple sites in the bones, sir. There's femur, there's
is she symptomatic? Is she symptomatic? Is she in visceral crisis?
She's not in visceral crisis, but she's symptomatic, sir.
She's symptomatic for the bone pain, you mean?
Yes, sir. She had also received actually PAL-RT, and despite that, after that also there was progression. Currently, she's symptomatic, sir.
And she's on bone, and I assume that she's on bone modifying agents as well already, like zoledronic acid or denosumab. She already is on bone modifying.
Yes, sir. Yes, sir. She's on zoledronic acid, sir.
And despite that, the bone pain is still persisting. I think I would probably, stick my neck out and say probably this patient might actually benefit more from, chemotherapy, given that he's progressed on 2 lines of therapy, and probably would be more tempted to go with chemotherapy and then put them on maintenance strategy with, with hormonal manipulation after that. If she's very symptomatic and, like you said, even post palliative RT, she's still symptomatic with pain, I would be tempted to do that with bone modifying agents. Repeat a biopsy, look for the HER2 low or ultra low status. If so, plan for TDXT, otherwise chemotherapy, and then follow it up with hormonal therapy. And remember, there are a lot of updates even now from the current ESMO as well, where even giredestrant plus everolimus has also shown the more maximum. I mean, these are all cross trial comparisons, but you're spoiled for choices in the current era. So gedatolisib, which is a dual PIK3 and mTOR inhibitor, then giredestrant, then vepdegestrant, which is a PROTAC or proteolysis targeting Chimera. All these trials have read out in the current ESMO, albeit most of them not yet approved. But these are all phase 3 trials that I'm talking about. But nevertheless, I think if your patient is very symptomatic, large volume of disease despite PAL-RT, I would, favor giving chemotherapy here, or even repeat the receptor status if it's HER2 low, probably TDXT, and then try for hormone manipulation after the chemo as part of maintenance.
Thank you, sir.
And on progression, we may consider for a liquid biopsy with the comprehensive NGS, or a repeat biopsy with the comprehensive NGS.
Yeah, repeat biopsy definitely with the comprehensive genomic profiling.
And any comments on doing a HRD, because BRCA2 was VUS, germline was VUS, to look for functional status, whether HRD also in addition to that?
Definitely. And
tissue
probably,
biopsy.
I would probably look at all the other tumor agnostic markers as well.
Okay.
So, Narendran, I would probably look at doing all the tumor agnostic biomarkers along with HRD. If patient's got no financial constraints, I think I would definitely look at doing that. But the basic thing is to repeat a biopsy to look for HER2 low or ultra low status as well. And look at the strength of receptor expression as well. If the ER and PR are still strongly positive, is it still hormonal driven? Because I think, every time the progression-free interval is actually shortened, and last PFI is only around 4 to 5 months, and she's very symptomatic.
Yes, sir.
Yeah.
Thank you, sir.
So that last case, this 38-year female with a metastatic CA breast hormone positive disease, post 2 lines of hormonal therapy on progression. Now the limited gene panel has picked up PIK3CA mutation. So the final consensus, since the patient is very symptomatic, may go for a chemotherapy followed by a maintenance strategy if response is there with PIK3A inhibitor with fulvestrant or with the capivasertib with fulvestrant. And also consider for repeat biopsy to look for a head to low, ultra low status, and also possible NGS, which is a comprehensive NGS with the HRD. Since the BRCA2 VUS was there, can consider HRD also to look for a functional status.
And hope patient has already had OFS as well. I mean, I think I didn't ask that. I assumed that the patient has already had OFS.
BSO is done, sir.
Perfect. Okay.
So thank you, Kripa sir and Dr. Narendran sir. So over to the next case by Dr. Ashwin from Amla Institute of Medical Sciences. Yes, sir. Please proceed with the next case, sir.
Myself, Dr. Ritu. I am second year medical oncology resident. I will be presenting this case on behalf of Dr. Ashwin, sir.
Okay, ma'am. Please proceed.
So this is a case of a 69-year-old postmenopausal lady without any comorbidities. She had a family history with mother and father were survivors of CA lung and a uterine malignancy in her sister. She presented in our hospital in March 2025 with complaints of left-sided weakness. On examination, she had a performance status of 2. Left upper and lower limb had a power of 3/5. Next slide. Her MRI imaging showed a 1.9 into 2.1 centimeter lesion in the right frontal lobe and a 2 into 1.5 centimeter lesion in the right basifrontal region. PET CT showed a similar brain lesion which was avid and like multiple foci of ground glass opacities in the right lung. So this was suggesting of infective etiology. She underwent the excision biopsy of the space occupied lesion. The HPR was reported as high-grade malignant neoplasm. IHC turned out to be poorly differentiated adenocarcinoma. Next slide. So she had underwent a repeat MRI after this excision biopsy, which showed some enhancing dural nodules, which was a new finding suggestive of patchy meningeal mets. Next slide. So she was treated with a whole brain RT with a hippocampal avoidance, 30 grade 10 fractions. So this was her genomic study report. Next slide. Next slide, please. Okay, you can move on. Next slide. Okay, so currently the patient is not on any treatment. She is just on follow-up. Yeah, previous slide. Previous slide, please. Yeah. So our questions are whether any further treatment to be done, like any IHC to be needed. So patient is now relatively better, power has improved. So if at all she relapses, we have treatment options like immunotherapy, or we need to have an MSI testing in PDL1.
I think if Chandra ma'am is there, she can probably help throw some light on. I'm sure the patient requires additional IHC as well, but ma'am, if you're there.
Yes,
Can
sir.
you go back to the IHC slide? Biopsy.
Go back to that. Ma'am, can you put the IHC slide, ma'am?
Yeah, it's there.
Yeah.
So it is CK7 and EMA positive, CK20, TTF1, HMB45 ALK, and everything is negative. MAB index is 10, so it is 10 to 12%. So,
Yes.
Chandranam, do you want to add any other markers? Would you suggest to add any other markers for this one?
I don't know if you would agree, but definitely with clinical investigation, including imaging, only this has to be taken in consensus with. But anyway, whatever said and done, with or without imaging, this is not a complete immunohistochemistry panel for identification of primary. Where is the primary from? Will definitely require more markers. CK20, of course, will indicate large intestinal primary, but that alone is not sufficient. So two, three more panel of markers have to be added along with the CK20 to negate or confirm a colonic primary. And apart from intestine, there are other primaries as well. Even a mesothelioma, a genitourinary primary, and all those things also will have to be excluded. So I have already told you that disclaimer is always imaging clinical examination with IHC only will place the diagnosis. And of course, additional IHC panel is required 100%. And this is not a complete panel.
So I just had a question as well. I mean, like, has this patient had a history of prior hysterectomy?
Sorry, sir.
Does this patient have a history of prior hysterectomy?
No history, sir.
No history, patient. Okay,
No.
fine. The IHC profile to me seems like a gynecological origin, and especially with the molecular profiling as well. I read 1A, P10, and all of that. So probably I was thinking more like probably, if it's had been a hysterectomy, she's had a hysterectomy earlier, probably could have been an endometrioid or an endometrial cancer, which is probably the source of primary. But I would also suggest if the cost is not a constraint, you get a NGS done for tissue of origin testing as well. Or testing, like the Guardant Infinity, for example, which is the methylation-based signatures, which will tell you where the likely origin of the primary is from, as far as the site of origin of the primary is. So that would definitely be in order. And I'm sure even if you take this as CUP, patient needs systemic therapy. So, I think even if you take the CUP or a MU or a metastasis of unknown origin, you'll have to look at going on to systemic therapy. Why have you decided on, putting this patient on just follow-up? You said follow-up, right? If I remember right.
Yes, sir. Like patient was nil symptomatic and also like she
you
is
gave
free of
RT,
her symptoms. Power has improved. So
Was the patient given radiation, ma'am?
radiation is being given. After
Correct.
that only she is on follow-up.
I think she will definitely need systemic therapy for sure. And probably, either a platinum-based doublet, which is Pacli and Carbo, which is what we regularly do for all of our unknown primaries. I think you will need to do that. And in the meantime, get the rest of the workup done, like the additional IHC markers that were suggested and the tissue of origin testing, as far as either the Guardant Infinity or any other tissue of origin testing also, to look at identifying the primary. And then you could look at, changing your treatment pattern based on the molecular profiling as well. But from whatever is available, to the best of my knowledge, putting together the IHC and also the molecular profiling, the BARD1 P10, probably to me looks like a gynecological origin. You'll probably have to rule that out. If Dr. Arun,
But MSI also I think would help. If it is lost, it is confirmatory for like along with P10 and ARED1, like how you mentioned. MSI also could be taken. Yeah. Yes.
Correct. But have they done an MSI on IHC to the present?
No, I don't think they have.
Okay. That's not been done. It should definitely be done as well.
This NGS is targeted NGS, I think, sir.
Correct.
Can you go to the NGS? What are the genes tested?
If Dr. Arun Kumar sir is there, probably he can interpret.
And this patient has a family history of father, mother CA lung, and sister had a uterine cancer.
Exactly.
If I remember.
Yeah, that's a strong family history.
Yes, sir. I'm here. I just thought that I think this seems to be a broad panel only. But what is interesting in this report is, can I just go to that report? I don't know, is Dr. Divya here? I'm sorry, Vidya here? I'm not sure. So the blue one, yeah. No, yes, this MAP2 kinase 1 mutation is a loss of function mutation. Exon 2 del insertion it is given, right?
Yeah, in-frame deletion.
In-frame deletion. So it's quite interesting because you don't generally...
Activating actually. In fact,
it's activating.
technically. It is
So
technically
that's what I want to know.
activating. So basically there is a MAP kinase pathway that is now actually driving the disease. since the variant has, it has a, pathology, but we cannot use a standard therapy kind of an option there. But we know for sure because of this mutation, the downstream mTOR signaling is probably activated.
And also based on the molecular profile, ma'am, would you probably, because of the ARID1A and the P10, that probably it could be an endometrial primary? I mean, like probably, could you probably help?
Possible, sir. But then now that you told again that there is a strong family history also, it doesn't fit into a classical syndromic presentation, but it was like a familial kind of thing. Maybe we should do a broader hereditary panel.
Yeah, that definitely is.
And it may fit into endometrium because we know MAP kinase pathway is also one of the altering mechanisms in CA endometrium, right, sir? A small proportion of CA endometrium.
Great.
So P10 loss in fact facilitates the proliferation much more effectively. That's what we can infer from this variant. Off-label, we can think of the downstream blocking beyond MAP kinase maybe.
Perfect. I think to me, I think probably start off with a IHC, broader based IHC panel, and then get a tissue of origin testing as well. And start off with the patient definitely needs systemic therapy, Pacli and Carbo. Start off with Pacli Carbo and then refine based on your molecular testing reports. I think that would be my way to go forward. No, Joseph sir, Dominic sir, if you're there, probably you can add or pitch in as well, sir.
I saw something on PMS2 in this case. So,
yeah, probably.
I'm not wrong. I saw something with PMS2. So, where does that fit in right now?
Go to the next slide.
It was a VUS.
Okay.
Okay.
Okay. Maybe the molecular people here would tell us whether you would look at the PMS2 a little more closely or rerun MSI by PCR and by IHC and take it from there.
So generally PMS2 and MSH6, they both have low penetrance for all mild risk associated with all the cancer. Maybe so we can look into MSI part, maybe a hypermethylation or epigenetic modification to the MMR genes could have played a role. So I think IHC as well as MSI marker will be helpful in this case. That's my thoughts.
Okay. I just have one question. Arun Kumar, I think Kripa was telling cell of origin to infinity. Whether how useful it will be checking for the methylation and how useful the test is. Is there any like we have a lot of carcinoma of unknown origin. Sending these tests for cell of origin is checking for the methylation. How useful it will be to identify the primary actually.
It is, Doctor. I mean, it all started with RNA expression profiling, but to add with that, I think now panels have also started including methylation. It is becoming more robust in terms of identifying the cell of origin. Particularly in many CUPs, it does give you very good. Instead of broadly starting on platinum, it can tell you what type of origin it is, and it does help. So it has improved from what few years ago.
Correct. And probably just to add to that, sir.
Personal experience, Kripa, I think you have mentioned multiple times.
Yes, sir. I think I mean, I've done it both from Guardant as well as from Tempus also, because Tempus has got a transcriptomics based tissue of origin testing as well. So I think we're moving forward. I think we're looking at multiomics, both methylation based, transcriptomics, fragmentomics, all of them put together. But it's been very helpful, like Dr. Arun Kumar sir pointed out rightly. It probably helps reclassify in about 1/3 of patients, as far as molecularly subtyping them and putting them into a phenotype is concerned. So I think definitely like helpful if cost is not a constraint, because all of these tests are pretty expensive, as in the current era. I mean, like they're on its tracks. So if the patient can afford to do it, I think I would definitely, we should look at getting it done if cost is not a constraint.
Recently, I've done exosomal study for cell of origin to strand actually. So how is it actually? Is it anybody has used that to check the exosomes and cell of to identify the cell of origin?
No, doctor, I've not come across that.
You're not. Okay, fine.
So I
Fine.
have a
Thank you. We can
question here,
proceed.
sir.
You mean
Just a
exomes,
point of
sir?
clarification.
Exomes. It's exomes.
Exomes. Okay.
EV, yeah.
That is, I've done for a patient with splenomegaly with no other cause identified. That patient I've done an exome, but finally it came inconclusive. So
okay.
Yeah, see, I think extracellular vesicles or exomes. I think that's also like I said, probably the ideal test would be there's no such thing as a single ideal test. So probably moving forward, it'll all be multi-omics, putting together all of this and seeing that probably where these molecular signatures will take us as far as identifying the primary is concerned.
So because these numbers are small, probably all of us should put 1 or 2 cases what we have done and check it out what's happening. Probably that's how we need to go. Thank you. I think we need to proceed with the case. Thank you.
So this case, any other comments, sir, or go for a final conclusion?
Yeah, Narendran, I think the final conclusion, yeah, like we discussed, the additional IHC markers, get a cell of origin testing, tissue of origin testing if feasible, and so start off on PACLI and carbo, and then refine treatment accordingly based on the molecular pattern.
Also consider MSI by IHC or PCR.
IHC markers, always. All the additional IHC markers, including MSI as well.
Okay, sir. Thank you, sir.
Okay, sir. Thank you, sir. And the next case is by Dr. Balaji, sir, from Kamoksha Memorial Hospital. Yes, sir. Balaji, sir.
Good evening, ma'am. Hello,
Sir,
can you hear me?
sir?
Yes, sir, we can hear.
Yes, sir, we can hear you, sir.
This is a follow-up of the ALK positive lung cancer. We are trying to personalize ALK inhibition for this patient.
Good evening, ma'am. The case details are, this is a 58-year-old male. We have already presented in the month of September. The primary lung cancer, stage 3 at the time of diagnosis. It was diagnosed in the month of July 2025. So that time during the tumor board discussion, the mutation, he got all positive mutation in the NGS. So we have advised to, patient was actually given hemostatic RT because he had hemoptysis of 2 episodes. So the forum has advised to stop radiation and proceed with lorlatinib. So, but there was a delay in procuring lorlatinib. So we have continued radiation. We gave 54 gray of radiation to the primary lung tumor. And now we got the medicine available. So we want to discuss the further
Patient response.
Patient has got partial response with radiation therapy. The pictures of the response is in the next slides. Sir, want to have few questions for discussion at this point.
So this was a stage 3 cancer initially and proceeded with the CCRT, right, doctor?
Not CCRT, ma'am. It was definitive radiation was given initially. Only one cycle of chemotherapy was given, pemetrexed carboplatin. But later on, we stopped chemotherapy and radiation therapy was given on a definitive basis.
Okay.
So, sir wanted to know the risk of pneumonitis post radiation therapy because we are not having effective data with lorlatinib after radiation therapy in lung cancer.
Now, patient has got lorlatinib. So we want to initiate lorlatinib.
So I think the most of the data for pneumonitis comes from EGFR TKIs, where we know the the RT-induced pneumonitis is pretty high. To quote the data again, if you look at the LAURA data, which is post CTRT, then the patient goes on maintenance with osimertinib until progression, and that's the data that we have post CTRT. So I think the pneumonitis rates were close to 40%. But then the treatment discontinuation rates were lesser than that. So I think that's definitely there. So I think the consensus would be to, probably if you've already given definitive RT, and that's, how long has it been? What is the time frame now between completion of RT up until now?
It's been 10 days now, sir.
All right. So, in that case, it's preferable to wait for another 2 to 3 weeks, at least for a month. I would say at least 4 to 6 weeks. But, and then start the patient on TKIs.
Dr. Balaji, can I take a question here?
Sir,
yes, sir.
Please, sir.
Yeah. This is stage 3 NSCLC ALK positive. Now, if at all in the early stage disease, we have some data with alectinib that too is post-surgery. Now, is this an off-label situation, or do you have a rationale for this?
Rationale for, sir?
For use of lorlatinib, sir. Because I don't think in stage 3 we have data for lorlatinib. We have data for alectinib, I think that is post-surgery, if I'm not wrong. Kripa referred to LAURA study for EGFR, but I don't think we have similar data for ALK, if I'm not wrong or if I'm not outdated.
No, we treated it as oligometastatic disease. There was multiple lung nodules.
Sir,
okay.
Yeah, if I can probably intervene, sir. I think, when it was presented as stage 4 disease, or probably stage 3 unresectable disease. So I think stage 3 unresectable bar stage 4, that's why we wanted to start on systemic therapy itself and hold the radiation, because it was for hemostatic RT. That was how it was started off, sir. So that was why the recommendation was to go ahead and start off on ALK TKI, given that it was an EML4 ALK fusion that has been picked up on the NGS, sir.
And the consensus last time was not to go for first generation and second generation.
The P53 mutation was there, Balaji sir.
Lorlatinib, third generation TKIs.
Patient had P53 mutation. That was we discussed, I think, P53 mutation. So it's a resistant mutation. So KRAS may not be the right choice. So we discussed regarding brigatinib versus lorlatinib, and finally we all thought lorlatinib will be the best choice. So
and also that we also discussed about the particular transcript. Here we don't know which transcript, V1, V2 or V3 transcript, which is usually picked up as far as ALK positivity is concerned. There is no.
It was V1.
It was V1. Okay, sir. V1 is per sensitive transcript.
That is why we discussed sequencing first generation and second generation rather than going for third generation also. But the consensus last time was to go to, since there was a P53 co-mutation, go for a third generation lorlatinib.
Sir,
correct, sir.
Doubt, Vijay here, sir.
Hello.
Sir, Dr. Vijay here.
Vijay.
Though we don't have a data of post-CTRT followed by any ALK inhibitor. Having said that, we now know post-surgery, we are having huge differences when we are knowing an ALK positivity and starting an alectinib. And also, we know they are anyway going to progress. Why not off-label start? Why do we wait for a data for in such situations wherein it is so obvious?
This patient had stage 4 disease, Vijay.
If not for a stage 3, if we have a post-CTRT stage 3 status and ALK positivity has been proven, should we still wait for a data for us to start? Is it okay convinced for us to start off-label in such proper targeted stories which we know is there available already?
See, correct, but it's just like the ADAURA and the LAURA data that's come out. We know earlier on that we just have to wait for the data to come out, because that sort of justifies and it gives us a label and just says, okay, fine, this is an approved indication for us to be using an expensive drug, and so how long should we continue? Should we continue for 2 years, 3 years until progression? Unanswered questions, and given that we don't know the exact magnitude of benefit unless and until it's been replicated into a clinical trial. So that's why I think evidence-based medicine, we'll probably have to wait. But like you rightly said, the rationale and the hypothesis definitely yes. Absolutely no denying that fact. But yes, we'll have to wait for the data to roll out. Because remember earlier, if you talk about durvalumab, which was being used even in patients who had EGFR positivity post CTRT, the approval does not exclude those patients. But now that we have the LAURA data, we are not doing that. We are only putting them on osimertinib. We're not using durvalumab in those patients. But we always knew that the scientific rationale and hypothesis was already there. So I think it's prudent enough for us to wait for that data before we actually start offering it to everyone. But nevertheless, makes for shared decision making, and those trials are actually on. I mean, like whatever we're just discussing right now, those clinical trials are actually happening even right now.
So we can
Even
answer like we'll have to put into trial rather than starting off.
That's right.
One more point is, if it is a stage 3, and as Dr. Dominic was telling, we would have been more keen in giving chemo radiation. Here, only one cycle pemetrexed we gave. After that, once the ALK came positive, we shifted. Probably we'll treat with a curative intent. We'll try if the patient fails and if there is a residual disease, whether to add treatment lorlatinib that time or on progression will be the discussion.
That's right, sir. I think that's the question which Vijay is trying to ask us.
Yeah.
Sir.
So that.
Possibility,
So
would you the post of CTRT would we look at doing?
That is an informed decision. I think, as Dr. Vijay has said, it's an informed decision.
That's
yes,
right.
We need to explain what are the datas we have. Still, we feel it's a, we all know when there is a fusion there, patient is going to progress. Putting them early will be a better choice because it's a small molecule. If it's for a chemotherapy, probably we'll wait for progression. For lorlatinib, probably it's an informed decision, informing them, yes, he is right. Probably we all will discuss that with the patient.
The critical question is, should we how long should we wait to initiate lorlatinib? Because the patient has been dispensed with 3 months of lorlatinib now.
For radiation, if you check the trial, I think 2 to 4 weeks washout period.
That's my point. In the Pacific trial, when we were combining after consolidation radiation durvalumab, the pneumonitis risk was not, and the volume of V20 was less than 35% in this case.
Yes, sir. So ideally is 2 to 4 weeks is that recommendation they have given. I think minimum at least 2 weeks we should wait. We'll see anybody.
2 to 3 weeks.
Trial 2 to 4 weeks. Ideally at least 2 weeks minimum we should wait before starting lorlatinib if the patient is stable and not progressing.
Okay, sir.
We can move on to next case, sir.
Okay. Thank you, Dr. Sanjaleka. Thank you, Dr. Narendran, for the opportunity. So this is a last case. So it's a, go to the next slide. So it's 52-year-old.
Dysphagia is due to?
Bilateral breast cancer, stage 4, diagnosed in 2020. Can you mute, Tamil, can you mute others, please?
Yes, I have that.
Yeah, okay. So a patient was diagnosed in 2020. Patient was in presently PS2, comorbidities, hypertension, no family history. Next slide, please. So patient is a ERPR HER2 positive. First line was trastuzumab, CDK inhibitor, and fulvestrant. Patient had progressive disease. Then TDM1 was given and exemestane was given, progressive disease. Oral capecitabine, lapatinib, herceptin, progressive disease. Then we discussed the option of TDXD. Repeat biopsy, IHC was still HER2 positive, but patient affordability, they cannot afford TDXD. So patient presently, we started the first cycle of gem carbo and sent a rebiopsy and sent it for NGS panel. Next slide, please. So next slide. Next slide. So this is the NGS panel report. So we have a PIK3CA mutation is there. We have a ESR mutation is there. Next slide, please. It's a 118 gene panel that we sent. So these are the positive mutation. Probably the driver is PIK3CA. That is a driving mutation that we see. VAF is 0.73%. Next slide. Next slide.
This is liquid biopsy, sir.
Yeah, it's a liquid biopsy. Okay. So my question is, patient cannot afford TDXD. We know that PIK3CA is a resistant pathway for HER2/neu. We have already exposed other HER2 anti-HER2/neu treatment. can we re-challenge targeting the PIK3CA mutation with alpelisib or going for capivasertib, fulvestrant plus trastuzumab, pertuzumab, because probably the HER2 resistant pathway is through PIK3CA. Will it re-challenging anti-HER2 will it work if the patient is not affording TDXT? This is the question I want to post.
So, Arun sir, if I might just quickly ask you, can the patient actually afford tucatinib?
Yes, patient exposed to lapatinib can afford tucatinib.
So if TDXT is not an option, then probably I would do hormones plus tucatinib. Has the patient had any hormonal therapy, sir, in the past?
Yes. Fulvestrant, letrozole, leximazepine, all three are over.
And progressed on all of that?
Or progressed. From 2020, she is on.
Okay, sir. Then probably I would do tucatinib plus trastuzumab plus capecitabine, just like how the HER2 climb data is, because the patient can't afford, TDXT, like you rightly said. And this point about PIK3C.
See, patient has already taken capacitabine plus lapatinib. Re-challenging with capacitabine and tucatinib, will it work?
Because that's so the thing is, ideally TDXT would be the perfect choice here, but given that you cannot afford it in that sort of a scenario, I think tucatinib would be the next best option out of all the that are available to us in India, is what I'm just talking about, sir. So I think tucatinib, and the data for the HER2 climb 2 comes from, again, tucatinib plus trastuzumab plus capecitabine. If not, you can even combine tucatinib plus TDM1 as well. Patient has already had TDM1, right, sir?
Yes, patient has completed.
Yeah, so that is another option. You can either combine it with TDM1 also, that we have the data for that as well. There is a PFS benefit of 2 months when we do that. Or again, tucatinib plus trastuzumab with capecitabine. And again, this point about PIK3CA, we know that even in de novo patients, about 30 to 40% can have PIK3CA mutation. If you look at the recent DB11 and the DB09, 05 data read out from ESMO 25, even those patients who had PIK3CA mutation also derived the same magnitude of benefit with TDXT. So I think, these are hot inflamed tumors. PIK3CA is one of those resistance mechanisms, agreed. But, to be combining that when the patient has not been exposed to all these lines of HER2-directed therapy, because I think this patient, you said the repeat biopsy is all to HER2 3+. So it's a HER2 tumor. So I would look at targeting the HER2, sir. Be it either with tucatinib or TDM1 plus tucatinib, given that your patient cannot afford TDXT. If the patient can afford TDXT would be the best option right away. And the patient has already progressed on all the hormonal lines of therapy, like you said. I think letrozole, fulvestrant, all of that. The patient has already been exposed to all of that.
Kripa, I just want to, what about fulvestrant, alpelisib plus pertuzumab and trastuzumab? Because we know there is a downstream pathway mutation. Whatever TDM1, all are going to be acting at the receptor level. We know there is a mutation downstream which is causing the proliferation. Will putting a patient on fulvestrant, alpelisib and re-challenging trastuzumab or pertuzumab, will that be a better choice than this? Why you consider your tucatinib plus capacitabine better than this choice, actually?
Exactly, sir. Because we are talking about introducing HER2-directed therapy which the patient has not been exposed to so far, rather than re-challenging. And this is primarily a HER2-driven disease. It's triple positive disease, but it's HER2. We classify it as HER2 low risk or high risk based on whether it's triple positive or true HER2 enriched. And here it's definitely the disease is HER2 driven. So we'll have to look at targeting the HER2, and by that I would probably look at using an agent which I have not exposed the patient to prior, before looking at re-challenging or running out of options where I look at re-challenging, sir. And again, the question as to why not combine everything together, I think I'm worried about toxicity, especially with alpelisib. It's a very toxic drug. And again, if you're going to add pertuzumab and all of that, diarrhea also becomes another concern. So I'm worried about toxicity if I'm going to add everything together at one go. So and the reason why I said probably I would either choose I would definitely look at using tucatinib here, sir, in whatever combination I can. But I think tucatinib would definitely be a better option, because we know the data that we have, is definitely better. When compared to either the NALA data, which is neratinib plus capecitabine versus LabCap, we know neratinib plus capecitabine is better, at least based on whatever data that we have. And likewise, the tucatinib data, again, cross-trial comparisons also, it's definitely better, much better CNS activity, We know all of that. That data is already there. And again, TDM1 plus tucatinib also, that data is also there. I mean, we have that available. So I think I would either choose between TDM1 plus tucatinib or again, tucatinib plus capecitabine plus trastuzumab.
Just to add on, sir,
Arun,
HER2 climb also had patients who were exposed to lapatinib and then now getting tucatinib. So post lapatinib, tucatinib is also possible. I think sir had that doubt as well.
Okay.
Yeah.
Thank you.
There is one more observation here, sir. It's just not one downstream mutation. There are two mutations there in this particular profile. One is the loss of NF1 is also there. So NF1 loss is a negative regulator for the PI3K MAP kinase pathway. So although there is a driver in PIK3CA, downstream NF1 loss is also there. So if we want to block the proliferation, the ideal molecule would be an mTOR inhibitor if we just go by the pathway analysis.
Thank you, Dr. Vidya. Actually, I discussed that exemestane everolimus option. I discussed it because they wanted a break from all IV. As you rightly said, that option was thought. Thank you for your feedback. Thank you very much.
Could you please go back to previous slides?
Yeah, and also Dominic sir wanted to, sir, your thoughts? You want to...
I would probably repeat the PIK3CA on an earlier biopsy by PCR, probably assuming that PIK3CA is an early mutation. And if I find the mutation there, then somewhere I would try to bring in alpelisib because that's probably driving the tumor, and I would like to repeat it by on a block with a PCR.
Thank you. I brought this case for this discussion. I think you almost echoing what happened in my mind. That was my thought. But thanks to Krupa and others also, they have a different opinion. That's nice. Thank you.
Loss here is VUS, not pathogenic.
Correct.
Okay.
So as such, the PIK3CA yes. And sir, if patients started on tucatinib and trastuzumab with fulvestrant or capecitabine, whatever you said, if there is a shorter DFS, then you agree that it's a PIK3 driven disease here within 2 months, 3 months of the patient progress?
Yeah, I think, even then, we'll have to look at repeating the biopsy at that point in time, seeing if there is a loss of receptor status. I mean, because, this, like Arun sir rightly said, I think every time they repeat, it's always been HER2 positive and IHC on 3+. Is that right, Arun sir?
Yeah, correct. 3 times we have done.
Yeah, so on all the 3 times, it's been HER2 positive and IHC 3+. And what about the receptor positivity, sir? ERPR, is it strong positive? What is the ALRED score, sir?
I'm not sure of record, but it is positive. I don't know how strong. I'm not sure. It was positive.
Okay, sir. Probably not be worthwhile looking at how strongly.
And she did well on fulvestrant palbociclib. She went on for 3 years or 4 years. So which there was good response to endocrine treatment initially. With just trastuzumab.
Okay. I think, we have the data for Monarch her as well, Abima plus fulvestrant plus trastuzumab. That data is already there. We have that. But again, I mean, this patient has already been exposed to, I mean, have you given her CDK as well, sir?
Yes. She was on palbociclib. That's the initial CDK inhibitor for 3 years she was.
So since you've already done all of that, sir, I think, and that's the reason why I believe probably targeting the HER2 here, even in the PIK3 mutation, would actually be beneficial.
Here, tumor fraction is mentioned as 0.73%. Could you please go back to the previous slide, sir? Tumor fraction is mentioned as 0.73%, and the tumor fraction was derived based on the VAF. Dr. Vidya, if you are available, could you please comment on that?
It is
This is
just
liquid
not
biopsy.
based on VAF, sir. It is based on the proportion of
Yes,
ctDNA
that is how it should be.
fragments.
But here they have mentioned this tumor fraction is calculated based on the VAF and copy number.
Oh, okay. That means they purely went by the highest VAF and they have mentioned it there. But if you go by the definition,
Yes.
It
This is
involves
not the
more
right
than
way.
that. Yeah, no, sir. So there is this fragmentomics approach, right, where we look for
Mm.
the signals in the. There are certain
Yes, yes.
sequences
All
in the
signals
DNA.
needs to be captured, averaged
Yes.
out, and only then we can. Okay.
Yes, sir.
Actually, can you explain exactly the discussion between you both? Actually, because it'll be good. What was
Tumor
your
fraction. Tumor fraction is generally calculated based on the all the signatures, tumor signature that are captured in the DNA segment. So
Okay.
it is generated as a proportion. So here they have mentioned tumor fraction as the highest VAF what they have seen. So which is not the correct way of
Okay.
reporting tumor fraction.
Okay. Okay.
So in this case, so again, since the tumor fraction is 0.73%, this also questions the validity of this the report, if I'm not wrong.
Okay. I will discuss with the genome analysis molecular scientist there. It's
Yes,
a
sir.
valid point. I will discuss, and probably next tumor board I'll get back with their response.
Sure, sir.
Thank you.
Thank you, sir.
We have missed a case where case 4 is there. So we can go back to case 4. That's the last case for discussion today.
And last case for presentation is by Dr. Ruhi from Rajkot. Over to you, Ruhi. You can proceed with the case. This is the last case for today. Ruhi, are you there? Dr. Ruhi?
I think we have time. So some Tamil, can you call her, and then maybe in the chat box some questions are there. We'll have discussed for 5 minutes, and then if they are not
Yes, I
attending,
have
then
called them, ma'am, already.
Okay, in between we can, if she joins within 5 minutes, we can go for her case. The chat box, some questions are there.
Narendran, one of us can present the case. That's fine if she joins, because we have only 15 minutes.
She has put in the chat box, her case is missed.
Yeah, so if she's
So
not.
ma'am is joining right now.
Hi. Dr. Gautam Makadia here. I'm from Shashwat Hospitals, and Ruhi is with Shashwat Hospitals only. So I can present this case because I have treated him also. So it will utilize the time also. And when Ruhi will join, she will start the case.
So please
So
proceed, sir. You can present.
yeah, hello. Good afternoon to all. The patient is a 68-year gentleman without any comorbidity. He was having colonic carcinoma. In 2015, he was well treated post-surgery. And now presented with a relapse disease, or I should say a second primary disease in 2025, 19th of September. Performance status is fortunately still good. As I've discussed, there are no comorbidities. Family history was insignificant for this case. Please, next slide, please. Yeah, Ruhi has joined. Ruhi, you
Sir,
can take it forward.
yes, sir.
Yeah.
Thank you so much. Sorry for that due to network connection. So basically, like sir mentioned, the CA colon 2015 PT3N0, no adjuvant treatment was given, no chemo or radiation. Now he came with pancreatic mass and lung mets, and the lung lesion was biopsied, which showed intestinal differentiation, adenocarcinoma with intestinal differentiation, and CK20 positive, CDX2 positive, CK7 negative, suggestive of colorectal origin. But when we go to the PET CT scan, it only showed a pancreatic mass lesion with no nodes in the pelvis, no uptake in the colon or anywhere in the lower GI. And next slide, please. Hello, am I audible? Next slide, please. Put this up for tumor board discussion for the whether it's a new primary or not, because and how to go about the ideal treatment for this case, because there is no other lesion in the lower GI tract, or there are no pelvic nodes, there's no liver lesions, and on the scan there is a head of pancreas mass, which is like locally advanced type of picture, but there was no obstructive jaundice in this case. So our NGS report shows KRAS mutation, APC mutation, TMB is around 15.8, TP53 mutations. So I just wanted to know how to go about treating it, whether as a colon primary or a pancreatic primary.
Chandramouli Shri ma'am, can you comment on that IHC? The CK19 is
Yeah.
positive. So
Sure.
whether it can be an intestinal type periampullary here or
So CK19, see, all these markers are not very specific basically. So CK19 is a simple epithelial marker. It can come in any adenocarcinoma positive. So with that, trying to comment whether it is a colonic or a pancreatic primary may not be very helpful. But
I
the
think
other
7 and
IHC
19
markers,
is positive, I think.
7
sorry?
is negative, sir.
7 is negative. Okay.
Yeah, but that will be the case in both colonic primary as well as a pancreatic head of the pancreas tumor with an intestinal type of differentiation. So that CK20, CDX2, everything will be expressed both in pancreatic primary with an intestinal differentiation as well as in a colonic primary. So with IHC alone going in favor of a colonic primary in this particular case is not going to help you. So if there is no colonic lesion even on scopy, then I think you will have to take it as a pancreatic primary. And one more thing is SMAD4, which is written over here. So SMAD4 is another IHC marker which we use in case we happen to suspect a pancreatic carcinoma. But here it is written as positive, meaning is it normal? Usually SMAD4 loss.
Ma'am, it was
I think
retained. So that's what our
cancer, ma'am. So I mean, like, Chandra, ma'am.
Yes, sir.
Yeah, SMAD4 is very specific for colorectal cancer, isn't that right, ma'am? So here.
No, it isn't. No, it isn't basically. More like pancreatic, colorectal, or even head and neck tumors can express a SMAD4 loss. So SMAD4 loss, loss, it should be loss. It's not positive. Positive means it is normal. So normal cells express, loss is abnormal. I don't know. Here it is written as positive, which means it is normal only.
If it's pancreas, if it's SMAD4 mutation is there, the protein will be lost.
Yes,
so if it's
absolutely.
retained, there is no mutation. So in pancreas, mutation happens, so it will be lost. But in colon, it will be retained.
Absolutely, sir. But that again happens only in a certain percentage of cases. Around 30 to 40% of pancreatic primaries show a SMAD4 loss. So if it is lost, yes, it is contributory. But if it is retained, then again, I think we have to go back to our age-old methods of examination of the patient. So scopy, no primary, pancreas shows a mass, I think you have to take it as pancreatic primary still, sir. I think.
CDX2 positivity points towards the intestinal type here, ma'am.
Absolutely, sir. CDX2, that's why, sir, like I told you in the last case, it is a panel of markers, CK20, CDX2, and SAT-B2. Here, CDX2 and CK20 are positive, which is in favor of an intestinal primary. But like I said before, pancreatic tumor with an intestinal differentiation, pancreatic adenocarcinoma with an intestinal differentiation. Like you also were discussing in the previous case, right? Hepatobiliary and intestinal differentiation are the two histological subtypes in a pancreatic adenocarcinoma. So in a pancreatic adenocarcinoma, which is showing an intestinal type differentiation, definitely CK20 and CDX2 will be positive also. So just this IHC alone, I don't think you should go, sir. If there is no lesion in the colon, no, it is a pancreatic primary. Even if it is SMAD4 retained, even if it is CK20 positive and CDX2 positive. And I don't know about the genetics. Even genetics, I don't think it's 100% in this particular case.
Actually, imaging-wise, it was from the head of pancreas and periampullary area. And we have got the extensive discussion with the pathologist here. Yeah. And as the SMAD4 was retained in the IHC specimen, then we have interpreted as a primary apart from the pancreatic adenocarcinoma. It should be something like periampullary carcinoma with intestinal differentiation, or it is a colonic carcinoma. As the imaging is clearly not showing any evidence of a colonic disease right now in the PET CT scan, right now we are intending to proceed for a periampullary carcinoma with the intestinal differentiation in this case. Any difference of opinion from
Sir, only one doubt. Could we not do a
yeah,
scopy, sir? PET, is it capable of picking up even very small lesions in the colon? Is my only
yeah,
question here.
yeah. We will ensure this. Yeah, fine. Perfect.
Molecular scientific comments.
Actually, Dr.
Mhm.
Vidya Harini is familiar with the case. So, based on the NGS report, can
I think you're
we differentiate whether it's a primary, like can we pinpoint the primary based on the
Should I
based on the
comment
NGS
here, ma'am?
report?
Yeah. So,
Yes, ma'am.
so basically, sir, you see the TP53, KRAS, and APC, which is very classical for colorectal neoplasms, right? And we are seeing that in this patient. Of course, KRAS is also known in pancreatic cancers. And APC in a small proportion. But if you see that the classical picture is kind of reflecting here. So more favoring an intestinal type, intestinal origin, large intestine.
The TMB high of 15.82, does it warrant MSI? Does it tell us probably something is happening? MSI will help and
MSI done here, sir. Stable.
it's stable. Huh?
Stable.
Okay.
I think probably we could also look at doing a TO self origin or a TOO testing here. If that will actually add, if you're thinking more in terms of a periampullary with an intestinal type, which is what it looks like. But again, I think very specifically the SMAD4 as well. I mean, like we heard from Dr. Chandramouli as well. She said that may not be very specific, but nevertheless, the APC mutation and all the mutational profile definitely points towards a colonic phenotype here. So I think even if it is the intestinal subtype of periampullary, it might be worthwhile doing a CGP with cell of origin or tissue of origin testing as well. That can also help, provided the patient doesn't have any financial constraints.
Sir, what would be your best modality of treatment in this case?
So, Ruhi, I just want to understand what was the time frame between developing the second
Dev or FOLFIRINOX?
What is
2015 was the initial surgery.
10 years, sir.
2025 is second.
DFI is 10 years, sir.
10.
Yes, sir.
Okay. So that's then that's again another pointer towards a second malignancy rather than a
Yes, sir.
I think we're more likely to take it as probably a second primary malignancy, more likely a periampullary with intestinal differentiation or a colonic phenotype here. And you could do an NGS as well. And is it resectable now? Because you said it's only pancreatic, no distant metastasis, and is it?
No, sir. Lung mets is there, sir. So with lung mets.
Okay.
There are multiple lung nodules.
If the patient is fit,
Yes,
I
sir.
think FOLFIRINOX, I think that will cover all bases.
Yes, sir.
Both,
Yes, sir.
that's the answer.
Sir, comment on addition of bevacizumab, role of like if we should add bevacizumab upfront.
No, I don't.
Two drugs.
Yeah, I don't think.
Okay.
Yeah, you can wait, and probably the patient is fit. I mean, like do a triplet, FOLFIRINOX or epoxy, whichever you're comfortable with in your practice, or modify FOLFIRINOX also, and get a CGP done, including your TOO, I mean, like cell of origin testing as well. If again, like
I agree with Kripa. Yes, I do agree.
Yeah. I'm sorry. Am I audible? Am I?
Yes,
sir. Yes, sir.
I concur. I also agree with Kripa. Probably bevacizumab, no, FOLFIRINOX triplet should be fine because she's fit and if possible, triplet should be fine. And we can reassess after 3 months how she's doing.
Yes, sir.
How is the CEA, CA99 reports?
CA is elevated, sir, in hundreds. CA99 was not done. So we have to get that done. But since it was not, CA99 is not very specific and patient does not have.
We're not able to hear you clearly, Ruhi. Your voice is breaking.
Obstructive jaundice. So we are not sure what additional info. The CEA is elevated. CA99 is not done. Since it's a non-specific marker, we were not sure what additional information we will get, and patient does not have any obstructive jaundice as well.
Okay. Because that's strange for a periampullary to not present with obstructive jaundice. Okay. Yeah.
So, sir,
Can I have a
the
question
head
to
of pancreas mass is abutting the duodenum. Please, sir, go ahead, sir.
Dr. Chandramouli, how specific is SATB2 in this case? If SATB2 is positive, would you rule for colon?
Yes, sir. SATB2 is relatively more specific. You are right, sir. Absolutely on the dot. More specific when compared to CK20 and CDX2. But, sir, the thing is, mucinous tumors are always very dicey. The situation in dealing with the mucinous tumors, especially metastatic to the lung, is a little dicey. Like, nothing is 100% is what I have actually learned, and that's my humble opinion as well. Even if it is SATB2 positive, I think you would have to exhaust all of the diagnostic modalities before you even conclude that as a colonic primary would be my point on that.
Thank you.
I think we have finished all cases, sir. Chandralekha ma'am.
Yes, sir. Yes, sir. So this makes the end of the presentation for today. I thank the chairperson, Dr. Dominic, sir, for his valuable input. All the presenters for this wonderful discussion who made these discussions very insightful. And Kripasankar sir, Dr. Arun sir, Arun Seshachalam sir, Dr. Narendran sir, and everyone who had given their valuable comments and inputs for this fruitful discussion. And over to Arun sir.
Thank you. Thank you, Dr. Chandralekha. I know
Yes.
you're busy and for taking time and coordinating the whole program. I thank the chairperson, Dominic sir. I thank all the experts without whom this particular molecular tumor vote would not be possible. And as usual, Dr. Kripashankar, without him, this is not possible. So Dr. Narendran, Dr. Arun Kumar, Dr. Vidya, so everybody, all the experts, I thank you. Have a great day. Have a good Sunday tomorrow. Bye. Thank you.